Next, we're going to welcome Dr. Ali Fatemi from the Krieger Institute to talk about the CALYX study.
Thank you. Thanks for having me here. It's great to be back. Yeah, I'm just going to continue sort of the conversation that Mark started, talking about the adult active trial that we are recruiting, and I'd like to end it won't be that long, but I'd like to end it by getting hopefully some feedback from the audience about some challenges we're facing with identifying individuals with adult cerebral ALD that I think is it's really requiring from the community why we are stuck there. So just to be clear, as a disclosure, I'm an investigator at the Krieger Institute. I'm not affiliated with the company Minoryx, but obviously I received funding from the company for the trial, and a few of these slides are actually prepared by Minoryx. So, you know, we all, I think, know about this. This trial, CALYX study, is focusing specifically on males with adult cerebral ALD, so this subset of patients. And I think it's important to discuss briefly what we actually think is the prevalence of adult cerebral ALD, because it is the least studied, after, I would say, females with ALD, the adult cerebral ALD cases are the least studied subset of male patients with ALD. And so we're still learning. You guys can stop texting me, that would be great. I feel it in my pockets. Anyway, and so there are several challenges there. And I think the biggest challenge is actually that there isn't enough data, because we lose patients when they develop adult cerebral ALD, so we don't actually have good natural history data to know exactly how often that happens, to know exactly the rate of disease progression. We have extensive data now in boys with cerebral ALD, but this is still an emerging subcontinent. What we do know is that there seems to be at least 4 types of sort of adult cerebral ALD from the lesion description. And some of these images are actually from a paper by Florian Eichler here, where he looked looked way back at the larger data set that we had in Krieger. And so we see individuals that have in the first figure on the left, what we call the bilateral corticospinal tract involvement, and then there are those that have periventricular white matter involvement. And then there's a pretty significant set of patients that we see, and personally I feel like I'm seeing that more and more, with cerebellar involvement, white matter involvement. And then we have individuals like this one, this patient of ours, who had a fall. And after the fall, sustained a small subarachnoid hemorrhage in the frontal lobe. And then about 6 months later, the imaging showed that there was actually, this lesion was actually enhancing. And then another year later, that enhancement stopped. So this was sort of a trauma-induced focal cerebral demyelination. We've seen a similar picture with patients who have focal strokes in the brain, where we see a demyelination pattern following that, and then often it tends to stop by itself. So one big question that we're still trying to figure out is, of these individuals who develop adult cerebral ALD, what % of them will actually stop spontaneously without that intervention? And that's critical when we want to do an intervention, because otherwise we don't really know what we're measuring. And at least if you believe the data that Florian published several years ago in these individuals who have the periventricular white matter findings, at least half the time they seem to stop. And I would agree with that based on what we've seen. He may not remember that data, but that's so, but one of the things that we still think is the most reliable thing is gadolinium enhancement. If we do see gadolinium enhancement, we almost know for certain that at least for a certain amount of time that lesion will progress on the imaging. Whether you're an adult or a child, that doesn't seem to make a difference. And then again, because we don't have really good natural history data, we also don't know what is the prevalence and what is the exact survival rate of these individuals. We hear many stories like, oh, my uncle had AMN and then he became bedridden in his 60s and died. really the question comes up of did he develop cerebral ALD, and that's what really led to death. So there is an ongoing effort between Boston Group and Leipzig. I think we should give this talk. I might talk about it. And suggests that patients that have mild symptoms and get immune-enhancing immunizations, about 50% of them die within 3 to 4 years after that initial stage when you have these mild symptoms. And so that's pretty, concerning, obviously, outcome. Another effort has been by Bjorn Rangel, I think has come to this meeting in the past sometimes. It's a colleague of Stefan Kemp in the Netherlands, a neurologist who spent some time at the Krieger many years ago and published the first paper. And then he went back to the Netherlands and just a few years ago, well, it's been 10 already, published a follow-up paper to the original, trying to determine what is the rate of cerebral ALD in adults. And the Krieger data has 68 subjects, and the observational period was about 9.9 years. And that during that 9.9 year period, 19% developed adult cerebral ALD. The data was messy, especially if we ask Jay Reagan, he'll say it was messy. And that's because not everybody got repeated MRIs, and the timing was off and so on. So it's really challenging to really have a good estimate there. And it was again, it was a 9.9 year mean follow-up, but with a plus or minus 5.2 years. So, some patients had a much shorter observational period. And then he went and looked at the cohort that he was following in the Netherlands that was smaller. So, there's a bias there, obviously. It's a smaller cohort, and we don't know how many he lost because they were doing fine. That's sort of one of the arguments he has in his paper. But from these 27, 16 of them that were still alive, 16 of them, those who were alive, 16, they had an average follow-up period of 16 years. I think I got that right now. And when they looked in that cohort, as a total of 27 patients, 63% had developed cerebral demyelination. So the range seems to be somewhere in between. Now the initial, Kennedy study is probably an underestimate, and probably the Dutch study is an overestimate because again, he feels that individuals who are doing well may not have just come back as a web capture. But so this is as good as it gets so far. So we're still sort of struggling to get that number. But that's still a significant number if you think about the fact that 65% of those who have the G mutation and are males will go on to adulthood. That it appears that about half of them will develop at some point cerebral ALD. And so this is the data that we just saw, which was sort of the initial indication, the reason why glioblastoma was that pursued in cerebral ALD. This is what Dr. Martin just talked about, that we sort of in the advanced study with AMN, we saw that the incidence of cerebral lesion progression seemed to be lower in those who were treated. And then a little data is available about a compassionate use, but it's compassionate use, so it's not data that you can take into strong consideration to think about an effectiveness. It's basically what it is. It's compassionate use. You heard that there's 22 adults that have received the drug so far, but this is a paper that's coming out that is focusing on 13, and so obviously it's not with the entire group. And this is an effort led by Dr. Michelle, Professor Michelle. She allowed us to share this data. It's unpublished still. It's under review, so take it with a grain of salt. But from these 13 subjects, one died due to COVID, one patient became bedridden within 8 months, one patient clinically deteriorated, and then from the 10 that remained clinically stable, one of them had imaging that was too motion artifact affected, so had to be excluded, and you see here the plot of the other 9 that were clinically stable. And from those individuals that are clinically stable, and this is 3 months, 6 months, 9 months, 12 months, 18 months, and on a few of them we have 24 months data now. And these individuals, you see that 2 of them had significant lesion volume progression, but 7 of them appeared to be more or less stable during this observational period. But again, that's sort of 10 out of the 13 subjects total, which is out of the 22 total have got compassion use, so we don't know what is happening to the other. I don't know at least what's happening to the remaining 9 subjects now got the drug. But all of this data was sort of the indication to move forward with the CALYX study to really try to get an answer, is this drug doing anything in adult cerebral ALD or not? And there was a lot of discussion with the FDA trying to decide what would be a suitable outcome measure. And what we all agreed on at the end, or the FDA agreed on, was solely survival. And that's because, again, of the lack of really good existing natural history data that they were willing to take on. So it's tough when you use survival as an outcome in the study, obviously. That's a very hard decision. The FDA also insisted that it had to be placebo-controlled, and in order to get the sample size right, the only way to do that was around 1-to-1 randomization. So one patient is randomly enrolled into to get the drug, the other gets randomly the placebo. And so this is basically targeting, aiming to recruit 40 patients, and you heard it's a study going on in the US and South America. It's for males between, basically any male older than 18. And the primary endpoint is, again, either it's survival or bedridden with permanent ventilatory support. So somebody is basically ventilator dependent. We have a bunch of secondary outcomes, of course, like the MRI scores, as you heard, clinical progression scores, and so on. And we're also doing some safety studies as part of the assessments, although there is already a lot of safety data emerging from the other trials. So in order to be enrolled into this study, one has to be older than 18, like I mentioned, and there has to be evidence of progressive cerebral ALD, so there have to be gadolinium-enhancing brain lesions on the MRI. And it has to be somebody where they are not willing to get bone marrow transplantation, so either it's not recommended or it's just not an option for the patient, or they don't want to do it. Those individuals with a less score of 12 or greater than 12 are excluded because the feeling was that that's way too advanced disease. You can also think about those individuals that you saw in the compassionate use that had the higher lesion volume were the ones that seem to show more progression. Also, if you had prior bone marrow transplant, you don't qualify, or gene therapy, you won't qualify for the study. So the approach is to basically do this randomization, treat, and then after 18 months to do an interim analysis and see if there is any clear visible effect. If there is an obvious effect at 18 months, then we will go back to the FDA and say, hey, this is really obvious, it's not right to continue it as a placebo-controlled study. If it's not obvious, or if the FDA doesn't agree at that point, we would continue and do the same assessment again at 27 months. And then, if again there is no clear evidence, then we would go on all the way to 36 months and see if there is any difference there. There's planned for an open label extension in which everybody then will go over, depending on whether it's what we see in this drugs. So these are the study sites across the US. You see we have several sites, and then we have also 2 sites in South America. But part of the challenge we've had, and again, I want to just have that discussion briefly here, is that enrollment has been difficult. And of course, we are talking about a subset of a rare disease. But we feel that part of the challenge is that there are males out there who should be getting an MRI and are not getting an MRI. So one of our strongest recommendations for many years has been, and it's part of the publication of the National Consensus Guidelines, is that all males should be getting annual MRIs during adulthood. And the reason that's important is A, because of what I just told you about adult cerebral ALD. B, because now we have an opportunity to participate in clinical trials. C, because we need to get that information, even if it ends up not benefiting that individual, that will be benefits for others in the long term. But I would argue, as someone who's seen patients in the clinic die, that it is important to know. It is important to know because when you know what is going to happen to you, you can plan life in advance. And the last thing you want to do is be in a situation where you don't plan your life in advance. And we've seen people ending up on the street, we've seen people ending up at home malnourished because they didn't plan, they didn't want to know, and then end up in that stage where there's, it's a little bit like dementia. When you get the symptoms, you don't realize it first, and then by the time it is really bad, you're still not aware of it, and you're totally dependent on other people. And so if you know about this disease, then you can do estate planning, you can plan for your children, you can plan for your family members, you can make sure that you're taken care of. So even if you go in the process and say, well, these therapies don't work, it really has a great impact on the quality of life of the individual and the family. So I think it's critical that MRI is done every year. I think every physician in this room will agree with me. But it's not happening. It's not happening. And one of the questions that I have for the audience, especially for the men, is what the barriers are, what the challenges are. And I was hoping we can spend, is it okay to spend a few minutes on that? Just leave it up to the audience and see what the comments are.
I just had a question on enrollment. So you've got a number of centers that are involved in this study. Are people from different countries welcome to enroll if they're willing to travel to one of these centers?
I think the answer is yes. Yeah. And the travel costs will be covered.
Yeah, I think when I've talked with other men with AMN, not wanting to get an MRI is a couple of things. It's the challenges, it's the cost, potentially the cost. It's sadly not wanting to know, and that's the biggest push. And your Joy Connect, the last webinar was eye-opening for a lot of guys, and I think we got some more talking, and they're starting to understand the importance of the MRI and that there is an option out there. I said after that webinar, I know in the past, I've heard the doctors say a bone marrow transplant, but they've never gone into the specifics. And so okay, and then they would say, oh, there's a lot of risks. And that right there literally just made it seem like, okay, that's not an option. And after that webinar, I think that really opened up a lot of people's eyes. It is an option, but you need to get an MRI. But it's getting them to do it. And I brought it up just asking, and you don't get much feedback too from guys. And a lot of guys like to, they just don't want to talk about it. But that's just a guy being a guy, regardless if they have AMN or whatnot. But that's what I can offer.
Thanks for the update on last week's talk. I'm glad to hear that actually. That there is some move there. Yeah. Right.
Also, as a guy with ALD, I also don't like to talk about it. I get my annual MRIs. I've had 2 now. And I'll have another one in 6 months. For us personally, I understand the costs, and we're fairly well informed now. Cost is a big. Insurance is not covering my MRIs, and we're talking about $400 or $500 a month. Right, so if you do need MRI every 6 months, we're talking about possibly $1,000 a year. And given the financial state of the country, that may not be an option for some people. Also, depending on where you live in the country, it may not be explained very well to you, what ALD is and what treatment plans may be available to you as an adult male. So it could be just an information barrier about, why the MRI could be necessary and what your treatment options may be, along the line.
Yeah, we spend a fair amount of time writing letters of medical necessity for these MRIs to happen. And, I honestly don't know last time that it didn't finally get through. I didn't realize it was for you, but we sometimes have to fight with them, and they are basically looking for some keywords. And so one of the things that we can borrow from the cancer field is say monitoring disease surveillance, and then it seems like that sticks with most of the insurance companies. And so we just make it look like this is really what it is, right? But there are some keywords that seem to be getting. catch. Yeah. Thanks for sharing that.
I was just curious too, with regard to the importance of men getting annual MRIs. I have a number of families that will reach out to me from Canada from time to time, and the parents might reach out to me with some questions, and sometimes the advice they're getting is that, oh, you've had this lesion, nothing has happened with it in the last few years, so you don't need to be going in for these MRIs, which to me leaves these patients at significant risk. Are there any opportunities for more education from practitioners surrounding this so that these patients are getting the advice of it's recommended that they're getting in there and have this, evaluation done to see where they stand?
And I totally share that experience with you, that's what often happens is like they do get their MRIs and the local primary care is like, well, it's been the same now for the last 3 years, we don't need to. But what we do see is that this disease can activate at any age. I don't want to sound too pessimistic here, but it's we used to always say, well, you're in your 60s, it's probably not going to happen anymore, right? And we had patients now in their early 70s developing adults that were doing well, that were doing really not too bad. I mean, they're walking around no cane, and then a lot of us really damaged, 71%. So it happens any age. It's not, it's less likely probably, but again, that's what we think because we don't really have the natural history study, especially in the older patients, in the uncle that became bedridden, we just don't know. Right? And that's part of it.
Just a comment on the cost because of the MRI, because in the trial we have what we call a pre-screening, other than the regular screening when a patient is potential candidate of a study that we also have something we call the pre-screening, which essentially is that for any adult ALD patient, they can go and do an MRI. And there's no need to know if the patient has a lesion or no lesion. If it's an adult ALD patient, can go and get an MRI every 6 months, and that's covered by the company. So there's no cost there, at least during the period of the trial is enrolling. That a regular MRI can be done at no cost for the patient. And actually there's even some economic compensation because of the cost that the patient has in terms of not working that day or whatever. So it really, in that period of time, the cost should not be something blocking the possibility of checking if the patient has cerebral CLD.
Thank you. I have 2 questions, and it's probably for both of you that might help people brainstorm. So when you're fielding the inquiries that come in, first, is there a breakdown of how many are going to the website versus they heard about it and then going to their trusted clinician to find out kind of what the deal is first? And then also, percentage-wise, how many men with ALD are filling out that inquiry form versus concerned family members and loved ones doing it on their behalf? It just might help.
I can answer the second one. The first one, I don't have any data to know where they're coming from. We're not capturing it. Are you capturing it? Oh, go ahead.
Thank you. So for that second part of the question in terms of where are they coming from, we have a website which is to explain about the study and garner any interest, which is for families, carers, and patients as well. And we get a mix of carers, families, and also patients coming into it. We've had over 200 applications into the website of interest. And we have a system where the investigator centers that are listed here, as well as Dr. Bonkowski, who's missing on that list as I see, so apologies for that.
Okay. Sorry.
Where the sites reach out to those interested parties to see if the patients are eligible for this pre-screening of an MRI. And that's where we get the drop-off of over 200 applications, and we've only had 20 or so pre-screening MRIs. So I think to the point of there is concern of actually having the MRI is stopping significant numbers of accessing, in a sense, something which is not really part of the study. So, which is the challenge of trying to get more men interested in understanding what, that this surveillance is important.
Yeah, my comment on this is like, what can we do to change the mind of those who don't want to know, right? I mean, there's obviously a fear associated with it, and that's why, I would assume. But is there something that, could be done to, and I think, if we were talking 10, 15 years ago, it was a lot more understandable, because at that time we didn't really have any bone marrow transplant data in adults, and we didn't have any clinical trials in adults. It was a very different sort of era. But we are in an era where we have these interventions now. Whether they are effective or not is something we're still working on, but it's a very different times. And so, I remember hearing exactly the same things 10, 15 years ago, right? It was like the fear of having an MRI and not wanting to know because there's nothing we can do about it. But I think there is, again, I come from a world where information is helpful. And it's how you deal with that information that can make it either helpful or it can make it a nightmare for you. But it's more that what to do with that information, and if you have the right sort of resources to take advantage of, even if it's negative information. But I just don't know how we can change that mindset. Any more comments? Any replies? You can private talk to me. I'm getting a lot of text, so feel free to text me now. Okay.